Hi and welcome to Nursing School Explained, and this video about respiratory terms and physiology. This video is intended to be a review for more of the respiratory kind of like critical care scenarios such as ARDS, acute respiratory distress syndrome, acute respiratory failure, and so forth. And really what I'm trying to do with this video is have you become familiar with these terms so that then when you hear them for the more complicated topics that you know exactly what we're talking about. So now first let's review the basic physiology. So as we know, we have our alveoli here in black, and the blood flows into the lungs from the pulmonary artery, and the blue here represents the deoxygenated blood. And so then CO2 is diffused into the alveoli, and then O2, oxygen coming in through the lungs and the alveoli, gets diffused into the pulmonary vein and then is transported to all the cells throughout the body. And this is by the simple principle of diffusion, like so many things in our body. So things move from an area of higher to a lower concentration. In this case, the atmospheric pressure is higher than the intrathoracic or intraalveolar pressure, therefore everything will diffuse. And then, so another important topic when talking about respiratory is oxygenation. And the oxygen in the body can really be found in two different places or measured in two different places. So first of all, it's dissolved in plasma, which is expressed as millimeters of mercury in the partial pressure of oxygenation. And then the other part is bound to the hemoglobin in comparison to the amount the hemoglobin can carry. So the amount of total hemoglobin available, and then how much of that is saturated with oxygen modules that can then be expressed in percentage, which is also our oxygen saturation or pulse oximetry that we'll get to in a little bit here. The other important term here to know is ventilation. So ventilation is the actual process of air moving in and out of the lungs, and that has two parts: inspiration and exhalation. And the change again happens because of the ventilation happens because of the change in the intrathoracic pressure. And again, the pressure in the atmosphere is higher than in the chest cavity, and so oxygen will just diffuse in from a high to a low concentration. And the exhalation, keep in mind, is a passive process because of this elastic recoil of the lungs. So actually the inhalation is more of an active process, although we're not usually aware of the inhalation. But then just by slowly recoiling the chest and all the accessory muscles, the intercostal muscles and the diaphragm moving back in their original position, is called the elastic recoil, the elastic recoil ability of the chest wall. And then, so over here, the other terms are compliance and resistance. And a lot of times you'll hear that when we talk about some critical care topics, and we'll get into those here. So compliance first is the ease of lung expansion. So it's basically the ability of the lungs to inflate and deflate, and that's the lung elasticity and again that chest wall recoil. Now when we have decreased compliance, then it's difficult to inflate the lungs, and there can be several causes that cause that. So the lungs are not easily expanded if there's fluid in the lungs, such as in pneumonia, pulmonary edema, or ARDS. If there's decreased elasticity of the lungs, so when now the alveoli are not as pliable, if you want to call it that, and easily open and close, such as in pulmonary fibrosis, we have problems with decreased compliance. Or when there's decreased lung movement, when now the lungs can't expand because there is fluid sitting in that pleural cavity due to a pleural effusion, for example. So these are all causes for decreased compliance. But the compliance can also be increased, and that would be to destruction of alveoli, such as we see in patients with COPD or emphysema, where the alveoli are hyperextended, and so now that alveoli is always kind of like hyperinflated, and that would be increased compliance. And the other term here is resistance. So resistance is when there is airflow difficulty during inspiration and expiration due to a change in airway diameter. So this is when we think about bronchoconstriction, when, for example, in asthma patients, all this inflammation makes the airways constricted and then causing a problem with resistance. So then there's more resistance and more force needed to get the air into the lungs, and that can cause some problems here because of that airway diameter. And just so you know, the triangle here means change. It's a very commonly used abbreviation in the medical field. I know we don't see much handwriting anymore, but it's a very easy way of saying change, and it's just something that I've been using over the years, and just so you know that that's what that means. Okay, and then another term we need to look at is ventilation and perfusion, and the abbreviation for it is VQ. Don't ask me who came up with that, why it's not V and P for perfusion, I don't know, it's called VQ. So V for ventilation and Q for perfusion. And normally we perfuse 4.5 liters per minute, so that's the typical cardiac output that flows throughout the body and then through the lungs to get oxygenated. And we strive for perfect balance, as always, for homeostasis. And that usually means that each 1 milliliter of air through the ventilation, so that inhalation and exhalation, is each 1 milliliter of air is there for each milliliter of blood, perfusion. So that would be a perfect 1-to-1 VQ ratio, right? Ventilation and perfusion, 1 ml each. And so that's a perfect system where everything works perfectly. But there is a term called a VQ mismatch. So now the ventilation and the perfusion are not matching. So we either have not enough air or not enough blood. It's usually the problem, right? We could have too much blood too in certain conditions, but that's less likely. And so when we have this VQ mismatch, when there's ventilation causes, that can be because of secretion. So think of somebody who has a lot of thick secretions and mucus, then the ventilation is not going to be so easy, that airflow in and out of the lungs. If there's bronchospasm, so if the bronchioles kind of constrict and they expand, that can cause problems with ventilation. If there is alveolar collapse, such as an atelectasis, it can cause problems with ventilation because now these alveoli are not able to perform the oxygenation by the principle of diffusion over here. And then also if there's pain, right? If there's pain in the chest cavity, patient tends to not want to take a very deep breath, and so that can be a problem with ventilation. And then perfusion causes, so causes now that pertain to the blood flow. So if we now don't have enough blood flow coming here, then the CO2 can't be diffused back into the alveoli, and then we don't have enough blood volume or enough hemoglobin molecules for the O2 to attach to. And causes can be pulmonary embolism. So now if there's a clot somewhere over here in the pulmonary artery, it's going to allow less blood to flow through. Or if we have anemia, so if we have less blood volume to begin with, then we're going to have problems with perfusion. And all these, so either ventilation or perfusion problems will lead to hypoxemia, so low oxygen in the blood, and the cure or the treatment is administer O2, and that can be as simple as a nasal cannula or a non-rebreather mask. Remember that when we administer a nasal cannula or a non-rebreather mask, we can't really regulate the percentage of O2 that we're giving the patient, so these causes are usually not as severe. Now then we have another term that we need to look at, which is called shunting. And that means that blood exits the heart without oxygenation. So now the blood is being shunted somewhere where it kind of bypasses the alveoli, right, or the lungs in general. And that can be due to an extreme VQ mismatch. So now we have an extreme ventilation and perfusion problem. And that can be either due to anatomic reasons, such as in structural heart defects, as in atrial septal defect or ventricular septal defect that we see in children. and sometimes even in adults. And then the other cause can be due to intrapulmonary problems such as ARDS, acute respiratory distress syndrome, or pneumonia. Now in this case, when there's shunting involved, that patient will also suffer from hypoxemia, so low oxygen in the blood, but just simple oxygen administration is not going to solve the problem because we have this extreme VQ mismatch. So now this patient is going to need mechanical ventilation and an increase in FiO2, and FiO2 stands for fraction of inspired oxygen. And that is basically the percentage that we give the patient, the percentage of oxygen we administer, and that can only be measured by a ventilator machine such as a ventilator. And so these are very important terms to know: oxygenation, ventilation, compliance resistant, ventilation perfusion, and shunting. And so then how do we measure this? So ABGs are going to be very important measures or blood tests to monitor, which gives us an idea about the patient's oxygenation status and their acid-base balance, because we know that the respiratory and renal system work together to maintain pH balance. And ABGs usually give us the pH, the PaCO2, the PaO2, the saturated O2, and then the bicarbonate in exchange for the hydrogen ion on the acidic side. And then for monitoring or nursing care, there are basically two different ways we can monitor the patient's respiratory status, which is simple as a pulse oximetry that we're probably all familiar with, that probe that we put on the patient's fingertip. And remember that it's normal to be about 94 to 99%, depending on what textbook you're looking at or what hospital you're working at. But it's less accurate if the O2 set is less than 70%, which means that it can differ by 4%. So if the patient's oxygenation shows 70%, it really could mean that it's 66 or 74. And there's a big difference between 66 and 74, although both are pretty bad numbers. And that here again measures the hemoglobin, the amount of oxygen bound to the hemoglobin in comparison to the amount that the hemoglobin can carry. So that is that percentage that we talked about over here. And then the other way we can measure the patient's respiratory status, which is a little bit more accurate, is CO2 monitoring. So we can measure both here, oxygen and CO2 in the body. And first of all, it can be transcutaneous, which is usually done in the pediatric or NICU population, which is basically an electrode that is placed on the skin that detects the patient's CO2 level. And there is also the end tidal CO2, and that basically means that at the end of the tidal volume, of the total volume that the patient can inhale and exhale, we're measuring the CO2 during the expiration. And that is only possible through various different methods. So that can be done through the endotracheal tube, through a tracheostomy, and even through a nasal cannula. So you might have seen these nasal cannulas that have a little bubble attached to them. And that little device is the device that picks up the CO2 that the patient is exhaling, and is oftentimes used in sedation procedures, such in the emergency department, or maybe in the operating room, or in the recovery room, or you might also see it when the patient is on a PCA pump, because then we worry about sedation, which can influence their respiratory status and rate, and so we want to monitor making sure that they are not hypoventilating, which we could detect by changes in their expired CO2. So thanks for watching this video on the respiratory terms and physiology, which serves as a baseline to look at the different respiratory disorders, specifically the critical care ones. And these are everything basically that we've listed here: pneumonia, pulmonary edema, ARDS, pleural effusion, COPD, asthma. There's all these conditions here that you'll find in another playlist where I explain those in more detail. But again, these terms are important to know. Thanks for watching Nursing School Explained. Please give me a thumbs up if you liked the video, and I'll see you soon.